Hello class, I'm Dr. Parth and welcome to the anatomy lecture. Today we'll be discussing with you the first part of the contents of the orbit. So there are two lectures of the contents of the orbit. The second one will be dealt in the another lecture. So from the demonstration you all know that the orbit is the pyramidal structure. Okay, they are the bony cavities which lodges your eyeballs. Okay, so there are various nerves, vessels, and mainly your three cranial nerves, a third, fourth, and sixth cranial nerve, right? And some part of the fifth cranial nerve even, which is present inside the orbit. Okay, so the orbits are basically pyramidal cavities. Okay, present um, inside the skull bone, and it is formed by the various bones such as the sphenoid bone, lacrimal bone, orbital part of the maxillary bone. Okay, and also the zygomatic bone. Okay, they all form all together. They form the orbit. So before watching the lecture, I would request you to first see the demonstration of the orbit. Okay, yeah. So the orbits basically are pyramidal cavities which is situated on each side of the root of the nose. Okay, and they provide the sockets for the rotatory movements of your eyeballs. Okay, yeah. First of all, let us see the contents of the orbit. So the most important content is the eyeball, and the eyeball will be dealt separately in histology even. Okay. Then there is this ocular fascia. There are two types of ocular fascia. The ocular fascia are the orbital fascia and the bulbar fascia. Okay. The orbital fascia will line the orbit, and the bulbar fascia will line the eyeball. Okay, so there are two types of fascia which we will be discussing. Then you have the muscles. So there are two sets of muscles, the involuntary muscles and the voluntary muscles. Okay, the voluntary muscles are total six in number, and the involuntary total seven in number. Sorry, and the involuntary muscles are three in number. Okay. There are vessels such as the ophthalmic artery, superior and inferior ophthalmic veins, and the lymphatics which is going out of the orbit. Okay, there are nerves. The most important nerve is the second cranial nerve. So total four cranial nerves are there in the orbit only. The second, which is the optic nerve, right? Then the third, that is oculomotor nerve. Then the fourth, trochlear nerve, and the sixth, that is the abducens nerve. Okay. There are few branches of the fifth cranial nerve, that is the ophthalmic nerve, maxillary nerve. Okay, and there are also some of the branches coming from the sympathetic plexus, even that is the superior cervical ganglion. Okay, so in this lecture, we will be discussing mainly about the voluntary muscles of the eyeball, their action, and the third, fourth, and sixth cranial nerve. Okay, other nerves and vessels will be dealt in the another lecture. Okay, the second part. Also in the orbit, the another content is the lacrimal gland, which we would have already discussed during the starting of the head and neck region. And there is this orbital fat. So the orbital fat is the most important part which supports your eyeball. Okay, yeah. So first coming to, towards the before going towards the orbital fascia, let me first discuss with you the visual axis and the orbital axis. This is a one marker question which you can be asked during your viva or during your examination even. So what is basically the visual axis and the orbital axis? So as you can see the medial wall. See, this is a medial wall of the orbit as they are pyramidal, right? So you can see this is the medial wall. They lie parallel to each other. Okay, this is the medial wall of the orbit. They lie parallel to each other, whereas the lateral wall of the orbit, right, they form 90 degrees with each other. Okay. Now the eyeball is situated inside this orbit. So the imaginary line passing through the anteroposterior diameter of the eyeball. See this one. This is the visual axis. Okay, this is the visual axis. Visual axis is what? It is the anteroposterior line passing through the center of the eyeball. That is your visual axis. This is the anterior pole and this is the posterior pole of the eyeball, and the line passing through it is the visual axis. And what do you mean by the orbital axis? Orbital axis is what? It is passing via the center of the base of the orbit. So this is the what you say, this is the pyramidal structure, right? Orbit is pyramidal, so this is the base of the orbit. So base of the orbit is nothing but your opening of the orbit, right? So this is the base of the orbit and this is the apex of the orbit. Okay, so an imaginary line passing through the center of the base towards the apex, see, that is your orbital axis. And you can see this purple colored line, the angle between the visual and the orbital axis is around 20 to 25 degrees. So this angle is around 20 to 25 degree, right? Okay, yeah, so this is about the visual axis and the orbital axis. Yeah. Now, first coming towards the orbital fascia. Now, see, the orbital fascia is basically the periosteum of the bony orbit. Okay, posteriorly, if you trace it, it will be continuous with the dura mater and the sheet of the optic nerve. See, posteriorly, if you trace this orbital fascia is also known as the periorbita. Posteriorly, if you trace it, it will be continuous with the dural sheet of the optic nerve. Anteriorly, if you trace it over here, anteriorly, it will be continuous with the periosteum lining the orbital margin over here. Okay, so this is the anterior margin of the periorbita or the orbital fascia. This is the posterior margin. Okay, now this is another figure you can see over here. See, posteriorly this periorbita, okay, is continuous with the dura mater of the optic nerve, right? And so anteriorly it is continuous with the periosteum of the bones forming the orbit. Okay, so this is the periosteum. Okay, it will be continuous as a periosteum. So this is the periorbita. Yeah. There are a few expansions given by this periorbita. The one of the most important is the orbital septum. See, this one is the orbital septum. See, that is the superior and inferior part of the periorbita, both give this type of expansion. Okay, that is the orbital septum. Okay, this is a flap-like continuation into the eyelids. See, these are the eyelids and these are the flap-like continuation over here, even inferiorly also. They are the flap-like continuation inside the eyelids. They are known as the orbital septum. Orbital septum is the continuation of the periorbita. Now, over here you can see this part. This part. Right? This is a gap in the periorbita. See, over here the periorbita inferiorly it is continuous with some sinus over here and also over here. Okay, so there is this gap over here. So this gap, okay, is bridged only by the connective tissue. Over here there is some sort of connective tissue and there is the presence of one involuntary muscle and that muscle is known as the orbitalis muscle. So this is the place where there is the position of an involuntary muscle, the orbitalis. Okay, there is a gap in the periorbita. Okay, over here they are not. It is not continuous in the posterior aspect and the inferior aspect of the orbit. It is not continuous, and this gap is bridged by connective tissue, and it consists of the orbitalis muscle. And the orbitalis muscle is an involuntary muscle whose function is still yet not known. Okay, so this is the only muscle in the orbit whose function is yet not known. Okay, the orbitalis muscle over here. Okay, so this is about the periorbita or the orbital fascia. Now the facial sheet of the eyeball, okay, or the bulbar fascia. First we talked about the fascia of the orbit, which lines the entire of the orbit. Okay, we saw over here. See, this is lining the entire orbit. It is lining the entire orbital bones. Okay, yeah, like this. So we first talked about the orbital fascia. Now we will talk about the eyeballs fascia, that is the bulbar fascia. Okay, so the bulbar fascia or the fascia bulbi is also known as the Tennant's capsule. Okay, it is also known as what? Your Tennant's capsule. So this Tennant's capsule is a thin, loose membranous sheet around the eyeball. See, this is a very loose membranous sheet around the eyeball. Okay, which is coming from your what? It is coming from your optic nerve only. Okay, it is extending from what? It is extending from the optic nerve towards the sclerocorneal junction. See, you can see this green colored structure over here. See, it is extending from your optic nerve. Okay, it is extending from the optic nerve towards the sclerocorneal junction. See this part. So this is your sclera. Okay, right? And this is your cornea. Over here is your cornea. So this much part is your sclerocorneal junction. This sclerocorneal junction is also known as the limbus. Okay, it is known as what? It is also known as the limbus. There will be few attachments of the muscles at the limbus. Now I won't be talking what do you mean by limbus. I am explaining the limbus right now only. So limbus is what? It is a sclerocorneal junction, and at this sclerocorneal junction you have the attachment of your bulbar fascia. Okay. Now this gap, this is the eyeball, okay, and this is the fascia bulbi or the Tennant's capsule. So this gap between the two is known as the episcleral space. Okay, this gap is known as what? Your episcleral space. So what is the function of this fascia bulbi is that it allows your eyeball to move along with the actions of the muscle. Okay, it provides a space for the eyeball to move with the muscles. Okay, so what is the peculiarities of this sheet is that it is pierced by the tendons of various extraocular muscles. You can see over here the superior rectus muscle is piercing this fascia bulbi, so get to insert it into the sclerocorneal junction. Okay, so it is pierced by the extraocular muscles. Also, it is pierced by some vessels and nerves of the eyeball. Okay, yeah. Now there are certain expansions given by this fascia bulbi. Now, what are these expansions? This is important. See, you can see this is a facial sheet. Okay, and over here it is inserted at where it is inserted at the sclerocorneal junction. Now you can see that this sheet are providing certain expansions to each and every muscle. Okay, see, it is providing the expansion to the ligaments or the attached part of the muscles. Okay, one of the most important expansion is the medial check ligament and the lateral check ligament. Now what are they? They are nothing but the tubular sheet. See, this is the sclera, okay, and this is your fascia bulbi, and this is a episcleral space. Okay, so now there is this lateral rectus muscle. Okay, so this fascia bulbi will engulf this lateral rectus muscle like this. Okay, also it will not only engulf the lateral rectus muscle, it will engulf each and every muscle. Okay, it will engulf like this, but on this lateral rectus muscle like this, after engulfing the lateral rectus muscle, it will go laterally to get attached onto the Wittnoll's tubercle. Okay, and this attachment of this fascia bulbi over here is known as the lateral check ligament. Okay, it is known as what? It is your lateral check ligament. Same way it is there on the medial side also, right? It is there on the medial side also. It is on the medial side, it engulfs the medial rectus muscle, and after engulfing it, it gets attached onto the lacrimal bone after forming the medial check ligament. So this is a medial check ligament. Now this fascia bulbi, which is covering the inferior rectus muscle and the inferior oblique muscle, is doing what? It is doing, it is continuous with the fascia covering the lateral rectus muscle, both the side, and the medial rectus also, like this. Okay, yeah, like this. And so this structure which is formed over here by the expansion of the fascia bulbi from the inferior oblique and the inferior rectus towards the lateral rectus and the medial rectus, this structure is known as the suspensory ligament of the eye or the Lockwood's ligament. So this is the formation of the Lockwood's ligament. Okay, this is the one of the another important structure which will suspend the eyeball. Another most important structure was the orbital fat. Okay, the second most important structure is this suspensory ligament of the Lockwood. Okay, yeah. So the suspensory ligament of the Lockwood is nothing but the expansion of what? It is the expansion of your fascia bulbi. Okay, so these are the two fascias which we discussed. Okay, the fascia bulbi is important. You can be asked the short note on the suspensory ligament of the Lockwood, its formation, then you have to explain like this. Okay, it is nothing but the thickening or the expansion of the fascia bulbi. Okay, yeah, see, this is the another figure. See, after covering the lateral rectus and the medial rectus, it gives the fibers to get attached onto what? Onto the bone. Over here is the Wittnoll's tubercle of the zygomatic bone, and this is a lateral check ligament. And over here is the what? It's the zygomatic bone, and it's the lacrimal bone. Okay, on the medial side it is a lacrimal bone, and it is forming the medial check ligament. Now this check ligaments and the inferior oblique and the inferior rectus, they all together form and thickening, and that thickening is known as what? Your suspensory ligament of the Lockwood. Okay. Now coming towards the extraocular muscles. Now there are two sets of muscles, the voluntary and the involuntary. The involuntary are three: the superior tarsus muscle, the inferior tarsus muscle, and the orbitalis muscle. The orbitalis we already discussed. The superior tarsus muscle is you can say it's attached to the superior tarsal plate of the upper eyelid. Okay, and its function is to elevate the eyelid. And the inferior tarsal muscle is attached to the inferior tarsal plate, and its function is to depress the lower eyelid. Okay, now coming towards the main important muscles of or the core of this lecture is the voluntary muscles, that is extraocular muscles, and there are four recti: the superior rectus muscle, the inferior rectus muscle, the medial rectus, the lateral rectus, and two obliques, that is the superior oblique, inferior oblique, and one another muscle, that is your levator palpebris superioris muscle. Okay, yeah. So now the origin of these voluntary muscles is common, the common tendinous ring of Zinn. Okay. Now this you all know, right? In the orbit you have the superior orbital fissure and the inferior orbital fissure. Okay, which transmits the nerves and vessels of the eyeball. Okay. So this common tendinous ring, this is an annular ring which is attached to the orbital surface of the apex of the orbit. This one. Okay. This is the common tendinous ring. Okay, it encloses the optic canal. See, this is the optic canal. So the common tendinous ring will enclose the optic canal and the middle part of the superior orbital fissure. Okay, this is the middle part of the superior orbital fissure. Okay, so over from this common tendinous ring, there will be the origin of which muscles? The superior rectus from the superior part, the lateral rectus from the lateral part, the medial rectus from the medial part, and the inferior rectus from the inferior part. You can see this another figure over here. See, this is the lateral rectus, this is a superior rectus, this is a medial rectus, and this is the inferior rectus. Now at this point, I would like to emphasize on the structures passing to from the superior orbital and the inferior orbital fissure. Okay, the structures passing through the superior orbital fissure outside the tendinous ring is this all structures. Okay, the lacrimal nerve, the frontal nerve, and the trochlear nerve. This is important. Okay, and the superior ophthalmic vein. Okay, yeah. So the trochlear nerve is outside this ring. Okay, this is important. Also, the lacrimal and the frontal nerve also is outside the ring. But the important point is the trochlear nerve, which is outside this ring. Now, inside the ring, as I already mentioned, it encloses the optic canal. So the optic nerve and the ophthalmic artery would be obviously inside this ring only. Okay. And the middle part of the superior orbital fissure passes what nerves? It passes the superior and the inferior division of the oculomotor nerve, abducens nerve, and the nasociliary nerve. And there is only one structure. This is the most important MCQ, that the only one structure passes through the inferior orbital fissure, and that is your inferior ophthalmic vein. Okay. Now coming back towards the extraocular muscle, we discussed the origin of this recti muscles. Now the levator palpebris superioris arises just above the origin of the superior rectus muscle from the orbital surface of the lesser wing of the sphenoid. Okay, so you can see this is a lesser wing of the sphenoid and this is the body of the sphenoid. Okay, so from here, the lesser wing of the sphenoid, there is an origin of the which muscle? The levator palpebris superioris. The superior oblique muscle, it is arising also from the body of the sphenoid. So this is the body of the sphenoid. So you can see this is the origin of the superior oblique muscle. Okay, the superior oblique muscle lies just supromedial to the optic nerve. See, this is a supromedial to the optic nerve. The origin of the inferior oblique. See, this is the origin of the inferior oblique. Okay, the inferior oblique is somewhat anterior. Okay, it lies somewhat anteriorly, and it is arising from where? It is arising from the orbital surface of the maxilla. So this is the orbital surface of the maxilla. Okay, and from this orbital surface of the maxilla, this muscle is arising from the anterior margin of the orbit. Okay, this is the inferior oblique muscle. Okay, you can see this is the superior oblique muscle, and these are the recti muscles. Okay, this is another figure showing the superior rectus muscle, the lateral rectus, the medial rectus, the inferior rectus, and over here, see, you can see this is the origin of the inferior oblique muscle, which lies at the anterior margin of the orbit. Yeah, now this is the levator palpebris superioris, and this is the muscle which is the superior oblique muscle. Okay, so now there are certain points for the insertion of this muscle. So the superior rectus, inferior rectus, medial rectus, and the lateral rectus, they all pass straight. Okay, you can see this, they are all passing straight. Okay, yeah, So this is a lateral rectus, this is a superior rectus, this is a medial rectus. Okay, they all pass straight and they get inserted into the sclera after piercing the fascia bulbi a little posterior to the limbus. Now the arrangement is such that the insertion of the medial rectus is at 5 mm from the sclerocorneal junction. So this is the superior rectus, this is a medial rectus. So this distance, okay, this is a sclerocorneal junction. So you can see this distance is only 5 mm. Okay, the distance between the insertion and the limbus is only 5 mm in case of medial rectus. In case of inferior rectus it is 6 mm. In case of the lateral rectus it is 7 mm, and in case of the superior rectus it is 8 mm. So the superior rectus is the farthest of the limbus. Okay, you can see this is 8 mm. Okay, and this is what? This is the lateral rectus is at 7 mm. Okay, so you have to remember this. Okay, the insertion, you have to remember that at what mm the muscles are inserted. Now the insertions of the superior oblique and the inferior oblique is slightly tricky, but you can see over here the superior oblique. Okay, it passes through the, first it passes forward, okay, straight forward, okay, and then at this point there is a presence of the trochlea. Okay, this is a fibrocartilaginous pulley, okay, which is attached to the frontal bone. This trochlea is a fibrocartilaginous pulley which is attached to what? It is attached to the frontal bone. Okay, then the tendon of this superior oblique will pass downwards, backwards and laterally. Okay, it is going downwards, backwards and laterally beneath the superior rectus. You can see it is beneath the superior rectus, and then it gets inserted into the sclera behind the equator of the eyeball between the superior rectus and the lateral rectus. Okay, so at first the tendon of the superior oblique, the muscle of the superior oblique passes straight forward, and then at the trochlea it takes a sharp turn, okay, backwards, downwards and towards the laterally, okay, beneath the superior rectus muscle, and then gets inserted behind the equator on the sclera just between the superior rectus muscle and the lateral rectus muscle. So this is the insertion of the superior oblique muscle. The inferior oblique muscle, see, after arising from the orbital surface of the maxilla on the anterior margin of the orbit, it passes beneath the inferior rectus. See, this is the inferior rectus coming, okay, and beneath it there is this inferior oblique muscle. Okay, the inferior oblique muscle then passes upwards, backwards and laterally to get inserted on the sclera. Okay, it gets inserted on the sclera between the lateral rectus and the inferior rectus. So this is the insertion of the inferior oblique muscle. Okay, you can see this is the superior oblique superior rectus muscle. Okay, this is the inferior rectus muscle, this is the lateral rectus muscle, and this is the medial rectus muscle. The recti muscles, they are like the cone. Okay, they are straightforward muscles, but the obliques, as the name suggests, they have an oblique insertion. Okay, yeah. So this was the insertion of the inferior oblique muscle. Now the levator palpebrae superioris. See, the levator palpebrae superioris, it also goes above the superior rectus muscle. See, it is going above the superior rectus muscle, and some books say that it is the separated part of the superior rectus muscle only. Okay, and as it goes forward, it gives three type of fibers. Okay, see, the voluntary fibers are the superior fibers which pierces the orbital septum. See, the superior fibers of the levator palpebrae superioris is piercing the orbital septum and is getting inserted into the eyelid after merging with which muscle? The orbicularis oculi. These muscles are the orbicularis oculi muscle. Okay, so after merging with the orbicularis oculi muscle, the voluntary fibers of the levator palpebrae superioris gets inserted into the eyelid. The intermediate fibers are involuntary and they get attached to the superior tarsal plate, and then it forms a superior tarsus muscle. So in the the starting of the lecture, we discussed the superior tarsus muscle. Okay, so they are nothing but the involuntary fibers of the levator palpebrae superioris. And the lowest fibers, see, these are the lowest fibers coming, they get inserted into the upper fornix of the conjunctiva. Okay, so this is the levator palpebrae superioris muscle. Okay, So the nerve supply, you have to remember the dictum, the all three SO4 LR6. So SO means superior oblique. SO4 is supplied by the fourth cranial nerve. Okay, and LR means lateral rectus is supplied by the sixth cranial nerve, that is the abducens nerve. Okay, we were discussing this nerve supply in detail in a few while. So first discussing the actions of this muscles. So you have to see that the actions are such that the eyeball movements, first you have to understand that the eyeball moves upwards. Upwards means it is elevation, then depression. The elevation and depression occurs in the transverse axis. Okay. Then there is an abduction and the adduction. Abduction means going away, and adduction means coming inside. So the abduction and adduction of the eyeball is occurring in the vertical axis. And there is another action of the eyeball, that is an intorsion and the extorsion. So the intorsion and the extorsion are defined in terms of the direction of the movement of the upper margin of the pupil. So see, this is the pupil. Okay, the upper margin of the pupil is at the 12 o'clock position. So if the pupil is going inside, that is on the medial side, okay, then it is known as an intorsion. And if it is going outside, okay, then it is known as what? It is extorsion. Okay, so there are this 6 movements of the eyeball. Okay, so it will so elevation of the eyeball, obviously it would be done by the superior rectus. You can see this arrow going above. Okay, this is done by the superior rectus. Now the medial rectus and the lateral rectus, first let me discuss this. The medial and the lateral rectus has only one function. The lateral rectus will always abduct. Okay, here they have mentioned the lateral rotation and the medial rotation, but they are also known as abduction and the adduction respectively. Okay, so the lateral rectus, the main function is the abduction. That means that your eyeball will go out of the means the eyeball will go out like that. Okay, and the medial rectus is the adduction. Okay, like this, it is the adduction. That is the only one function of the medial and the lateral rectus. So the superior rectus is basically your primary elevator of the eyeball. Also it helps the medial rectus in the adduction of the eyeball, and it is a intortor, that is the intorsion of the eyeball. The inferior rectus is the major depressor. Okay, the inferior rectus is a major depressor of the eyeball, and it helps the medial rectus for the your adduction, and the action of it is such that it will produce what? The extorsion. Okay, it will produce the extorsion. Okay, the inferior rectus will produce extorsion. Okay, yeah. The superior oblique, see, the superior oblique, as they are oblique, their direction will change. Okay, so the name is it is misleading. The superior, they never elevate, they will produce the depression. See, the actions you have to always learn by the insertion of the muscle. Okay, in this audio lecture, I cannot like show you that way, that how it will produce that action, right? You have to imagine, you have to see that the superior oblique is going laterally and downwards and backwards. So if you pull that muscle, okay, from the pulley, yeah, it is inserted from the trochlear pulley, right? If you insert it, it will definitely do the depression. Okay, it will definitely do the depression, and it will always produce your what? It will always produce your abduction. Okay, and it will produce your intorsion. So you have to remember that superiors, see, superior rectus is the intortor of the eyeball, and the superior oblique is the intortor of the eyeball. So superiors always intort. Okay, that is what you have to remember. And the inferior oblique, see, its section will be the completely opposite that of the superior oblique. Okay, so inferior oblique will produce what? Your elevation, and it will produce what? Your abduction, and it will produce the extorsion. See, both the muscles are producing what? It is producing the abduction. Why? Because they are inserting laterally. Okay, one thing. Now the inferior oblique, why it is doing the elevation? Because you can see from its insertion that it is going from beneath the eyeball, and then it is getting inserted into the lateral aspect of the eyeball. Okay, so if you pull that, it will definitely lead to what? Your elevation. Okay, if you pull that, it will definitely lead to the elevation. Okay, Fine. But the prime elevator is the superior rectus and the prime depressor is the inferior rectus. Okay. The prime abductor is the lateral rectus and the prime adductor is the medial rectus. Okay. Yeah. So these are the actions of the eyeball. So now there are this associated movements of the eyeball. That means that your eyeball moves in one direction only. Both the eyeballs will move in one direction only. So the coordinated movement, harmonious movement of the eyeball, they are known as your conjugate movement. But if this harmony or this coordination is broken, right, because of the paralysis of the nerve or any due to any reason, then that movement is known as a disconjugate movement of the eyeball, and that disconjugate movement is also known as the skew deviation. That means that your eyeballs are not in a one visual axis. Both the eyeballs has to be in one visual axis so that the image will be formed in the macula of the retina, and that will be transferred to the occipital lobe of the brain so that you can perceive one image. But if both the eyeballs are going incoordinated, then what will happen? There will be the two pictures on the macula, different images on the macula, and that will lead to the confusion of the occipital lobe, and that will lead to your what? Disconjugate movement. Okay. Yeah. So now coming towards the nerves of the orbit. So we are going to discuss over here the oculomotor nerve, the abducens nerve, and the trochlear nerve. So the oculomotor nerve supplies most of the muscles of the eyeball except for the lateral rectus, which is supplied by the abducens nerve, and the superior oblique, which is supplied by the fourth cranial nerve. Now, most important part about the oculomotor nerve is that all the muscles are supplied via their orbital surface. Okay, except for the inferior oblique, which is supplied from its posterior border. See, this is a posterior border of the inferior oblique, and the oculomotor nerve supplies the inferior oblique via its posterior border. But rest of the muscles are supplied via its orbital surface. Okay, you can see this is the orbital surface, this is the orbital surface, this is the orbital surface, and this is the orbital surface. Another important point about the oculomotor nerve is that it is dividing into the two branches, the superior and inferior branches, and it has a connection to the ciliary ganglion. Ciliary ganglion is very important short note for you people. It will be dealt in the another lecture. Okay. So the oculomotor nerve is basically your third cranial nerve. Okay. And over here we will be discussing the few part of the intracranial courses of this nerve even. Although this nerves, the intracranial part of this nerves will be dealt in the neuroanatomy also, but over here also I will be discussing some aspect of it. Okay. So the oculomotor nerve has the few functional components. The main important component is from the you can say the general somatic efferent for the movements of the eyeball, and the another one is the general visceral efferent, right, for the parasympathetic supply to the pupil, that is via the ciliary ganglion. Okay, and all the three nerves has a general somatic afferent. Why? There is an afferent from this nerve because for the, you can say, the proprioceptive impulses from this all muscles. Okay, the proprioceptive impulses from all these muscles will be taken by the oculomotor nerve, and it will be presented to the mesencephalic nucleus of the trigeminal nerve. But at this point, just remember right now that its main action or the main functional component is the general somatic efferent. Efferent means that giving, right, from the brain outside, right? So the main supply to the muscle is this. Okay. The another important is the general visceral efferent to the pupil, that is the function via the ciliary ganglion. Now first let us discuss about the origin of this nerve. So the oculomotor nerve nucleus, so this is the oculomotor nerve nucleus, okay, which is situated in the ventromedial part of the periaqueductal gray matter. So this is a periaqueductal gray matter, okay, this is a central canal, okay, this is the midbrain, okay, and this is the midbrain at the level of superior colliculus, okay. So the oculomotor nerve arises at the level of which? The superior colliculus. So this is the oculomotor nucleus, okay, and it is lying ventromedially to the periaqueductal gray matter. So from it, the nucleus, the nerve arises, and it goes forwards medial to the rad nucleus, medial to the substantia nigra, and medial to the crus cerebri. This is a crus cerebri. Okay, yeah. Apart from that, the nerve also carries the fibers from the Edinger Westphal nucleus. Also, it is related to the medial longitudinal bundle. Okay, the pyramidal tract. See, these are the intracranial or the intraneural connections of the third cranial nerve, which will be dealt in detail in your neuroanatomy session. So right now I will skip all that and I will just explain to you the course and distribution of this nerve. Okay, so it passes like this from the midbrain, and then it emerges from the anterior part of the medial side of the midbrain. Okay, just medial to the crus cerebri. Now, after coming out of the midbrain, it passes between the superior cerebellar artery and the posterior cerebral artery. Okay, and then it runs into the interpeduncular system. Okay, it runs into the interpeduncular system and goes laterally, lies lateral to the posterior clinoid process, and then pierces the posterior part of the roof of the cavernous sinus, right? And then it passes the cavernous sinus. Okay, and in the cavernous sinus, it is related to the trochlear nerve above. Okay, now after passing through the cavernous sinus, it goes forward and enters the orbit via what? Via the middle part of the superior orbital fissure, which we already saw in the over here also it is seen. See, this is the middle part of the superior orbital fissure. This green is what? It is your common tendinous ring. Okay, and this part and this part is the oculomotor nerve. So the oculomotor nerve is coming out via the middle part of the superior orbital fissure, and between their two divisions, see, this is the upper or the superior division of the oculomotor nerve, and this is the inferior division of the oculomotor nerve. So between the two division lies your NC, that is a nasociliary nerve. Okay, yeah. So it comes out of the superior orbital fissure, giving two branches, the upper division or the superior division and the lower or the inferior division. The upper division is thin. Okay, the upper division is thin and it passes forward to supply which muscle? The superior rectus and the levator palpebrae superioris from its orbital surface. Okay, the inferior division is thicker. Okay, the inferior division is thicker and the longest even. Okay, and it divides into three branches. You can see it is dividing into the three branches. This is the first one, this is the second one, and this is the third one. Yeah, so this one is the third one is supplying the medial rectus again from its orbital surface. The second one is supplying the inferior rectus via what? Via the orbital surface. And the first one, okay, this is important one. This is the longest division of the oculomotor nerve, which is supplying the inferior oblique via its posterior border. See, it is supplying the muscle via its posterior border. Now see, this nerve, the nerve to the inferior oblique, carries the parasympathetic fibers for the pupil, which is relaying into the ciliary ganglion. So the ciliary ganglion has a communication with the oculomotor nerve, right? And so this fibers of the inferior oblique are carrying the general visceral efferent to the parasympathetic part of the pupil for the accommodation. Okay, so this ciliary ganglion has a connection with the oculomotor nerve via the nerve to the inferior oblique. This is very, very, very important. Okay, yeah. So this is about the which nerve? The oculomotor nerve. Now the trochlear nerve. Now you can see the trochlear nerve. It was the only nerve which was coming out via the outer part of the outer part of the this common tendinous ring. See, this is a trochlear nerve coming via the upper part of the superior orbital fissure. The trochlear nerve is the fourth cranial nerve, which is supplying only one muscle, the superior oblique muscle, from its orbital surface. So this is a trochlear nerve which is supplying the which muscle? The superior oblique muscle. Okay, it is supplying the superior oblique muscle. So again, now it's intracranial and the intraneural course. So the trochlear nerve has certain peculiarities, that it is the only nerve inside our body that is a cranial nerve which has a complete decussation. Decussation means crossing with each other. Okay, so basically the trochlear nerve arises from the midbrain. Its nucleus is also situated on the ventromedial aspect of the periaqueductal gray matter. Okay, and it lies at the level of inferior colliculus. Okay, trochlear nerve was lying at the level of which? It was lying at the superior colliculus, but the trochlear nerve is lying at which level? The inferior colliculus level. So now, first it passes backwards and medially and it decussates with each other. Okay, it runs dorsally that is dorsally round the central gray matter to reach the upper part of the superior medullary vellum. So over here is the superior medullary vellum where there will be the decussation of the trochlear nerve. Okay, it is the only cranial nerve which will emerge on the dorsal aspect of the brain stem. Okay, now after emerging via the dorsal aspect of the brain stem, it will wind around the superior cerebellar peduncle and the superior cerebral peduncle. Okay, and passing laterally to the crus cerebri, it passes between the two arteries. Which artery? The superior cerebellar artery and the posterior cerebral artery. Okay, and then it enters what? It enters the interpeduncular cistern, and then it passes towards the cavernous sinus. By piercing the roof of the cavernous sinus posteriorly, it lies just above the just between the oculomotor and the ophthalmic nerve and lateral to the cavernous sinus. Obviously over here is a cavernous sinus, it is lying in the lateral wall of the cavernous sinus. Okay, and then at the anterior part of the sinus, it will open into the superior orbital fissure, right? It will open into the superior orbital fissure, the lateral part of the superior orbital fissure. It is not going in the middle part of the superior orbital fissure. Okay, now the nerve, after entering the superior orbital fissure, it will go medially. Okay, let's see, it is going medially above the origin of the levator palpebrae superioris. See, this is the origin of the levator palpebrae superioris. The nerve, the trochlear nerve, lies above the origin of the levator palpebrae superioris. It goes more and more medially, and then it supplies the superior oblique muscle via its orbital surface. Okay, so this is about the trochlear nerve. Now coming towards the abducens nerve. So the abducens nerve is a sixth cranial nerve which arises from the pons. Okay, so the nucleus of it lies on the upper part of the floor of the fourth ventricle. So behind the pons you have the fourth ventricle. Okay, so this is the abducens nucleus. Okay, it lies just beneath the facial colliculus. See, this is the motor nucleus or the facial colliculus of the facial nerve. It is lying just dorsal to that nucleus. Okay, and then it passes forwards to this, the nerve passes forwards to this facial colliculus. Okay, it runs ventrally. Okay, yeah, and downwards through the trapezoid body. So this is a trapezoid body, this is a trapezoid body, and this is the pyramidal tract. Okay, this is a trapezoid body. Okay, it is passing ventrally and downwards, okay, towards the basilar part of the pons. Okay, and ultimately reaches the lower border of the pons. See, this is the medulla oblongata. Okay, and this is the pons. Okay, so like this, the nerve goes like this. Okay, and comes out via the lower border of the pons. So it arises over here. Okay, it is arising over here inside the pons at the level of the facial colliculus. Then it is going ventrally and downwards. See, it is arising over here and it is going ventrally and downwards to come out of the pons via its lower border. Okay, and then it is turning upwards. So this is your first turn of the nerve. See, remember the abducens nerve has two turns. So I just explained you the first turn of the nerve. First it is arising over here and it is going ventrally and downwards to emerge of the lower border of the pons, crossing the trapezoid and the trapezoid body and the basilar part of the pons to emerge via the lower border of the pons. Okay, so this is the origin and this is the coming out of the nerve, and then after coming out of the lower border of the pons, it will go upwards, forwards and laterally through the cisterna pontis. Okay, it is going upwards, forwards and laterally like this. So this is the first turn of the nerve. Okay, from here ventrally downwards and then from the lower border of the pons upwards, forwards and laterally. So this is the first turn of the nerve. Then after coming to the first turn of after coming into the cisterna pontis, it will lie dorsal to this anterior inferior cerebellar artery. Okay, now it runs forwards into the cisterna pontis only. Okay, and then it pierces the cavernous sinus. So now I will be explaining to you the second turn of the nerve. Okay, the second turn of the nerve. Now the second turn of the nerve is at the apex of the pictus temporal. So this is the apex of the pictus temporal bone. Okay, so the nerve has to pass superior to the apex of the superior to the apex of the pictus temporal bone. Okay, as a nerve crosses the superior border of the pictus temporal bone, it passes beneath the pictosphenoidal ligament and then it will bend sharply forward. Okay, it is going sharply forward. So like this. Sorry, like this. See, it is going like this. Okay, like this. Over here is your apex of the petrous temporal bone, and it is going like this. So this is the second turn of the abducens nerve. Okay, this is the second turn of the abducens nerve. Now in the inside the cavernous sinus, see, it is piercing the posterior roof of the cavernous sinus, right? And in the cavernous sinus, it lies just lateral to the internal carotid artery, and then coming out of the sinus, it goes inside the middle part of the superior orbital fissure. See, abducens nerve is coming out via the middle part of the what? It is coming out via the middle part of the, see, over here is your abducens nerve, middle part of the superior orbital fissure. Okay, and it is supplying the lateral rectus via its orbital surface. Okay, so is this clear? This is very important. Abducens nerve has two turns. Okay, this is very important. Why? Because this two turns, or the two sharp bends of the nerve, make it very vulnerable, okay, to the stretching. Okay, also it has a very long intracranial course. See, after coming out of the pons, it passes into the cisterna pontis. Over here, see, it is having this second turn. Okay, first turn was like this. Okay, this is the second turn over the apex of the petrous temporal bone, and as you all know, the apex of the petrous temporal bone is very sharp. Okay, it just lies above the apex of the petrous temporal bone, and then it goes into the cavernous sinus, and then it goes inside the eyeball via the middle part of the superior orbital fissure. Okay, so this intracranial course of the abducens nerve is very important. Why? Because whenever you have an increased intracranial pressure, your brain will lead to what? It will lead to the descent of the midbrain, pons and medulla. So this is the brain stem. It will be the descent whenever there is an increased intracranial pressure, and as there is a descent like this, okay, it will pull the nerve backwards. Okay, and at the apex of the petrous temporal bone, it will be getting stretched and teared. Okay, and so that will lead to the abducens nerve palsy. So whenever a patient comes with the abducens nerve palsy, you have to always see the intracranial pressure. Why? Because of this reason. Okay, this is very important. The intracranial course of the abducens nerve. Okay, I will discuss that in a clinical part also in a while. So this is the relation of the nerve in the cavernous sinus. As you all know, this is the internal carotid artery with its and lying lateral and infralateral to it is your abducens nerve. Okay, so this is the oculomotor nerve. Okay, and beneath it is your trochlear nerve. Okay, these are the ophthalmic and the maxillary division of the trigeminal nerve. Yeah, this abducens and the trochlear nerve also carries this general visceral general somatic efferent towards their own muscles also. Okay, yeah. So now see, this is how the muscles are acting. Okay, now we are coming to the clinical part of the session. So the superior rectus is causing what? It will cause your, it causes your elevation, and inferior rectus causes your depression. It will cause abduction. So like this, it's your abduction. Okay, sorry, like this, it's your abduction, like this. Okay, so this is the actions, and this is how you check the muscles. Okay, you have to form an H shape. Okay, you form the H shape while testing the clinically. Okay, it would have been easy that if I would have been in front of you, then I would have shown you that how to test the muscles. Okay, so whenever you come back, just to remind me, I will show you how to test this muscles. Okay, now see, these are the clinical aspect, the strabismus or the squint. Now what do you mean by strabismus or the squint? Is that paralysis of a muscle will cause a squint or a strabismus. Strabismus is nothing but the disconjugate movements. Okay, so this is the squint. That means that if a muscle is paralyzed, okay, then the antagonist muscle, now you know that superior rectus is an elevator and inferior rectus is a depressor. Okay, so when the superior rectus is paralyzed, what would the inferior rectus do? It will pull the eyeball downwards. So over here you can see this one. Okay, this is the superior rectus palsy. Okay, that your inferior rectus will pull the eyeball beneath. Okay, so this is known as squint or the strabismus. Now there are two types of squint. One is a paralytic squint. Paralytic squint obviously happens when there is a paralysis of the muscle, and another is a concomitant squint, which is congenital. Okay, which is congenital. Now there is another clinical word, that is your diplopia. So diplopia is nothing but the dual vision or the double vision. Okay, when it occurs, it's the most common clinical symptom of the squint. Okay, so any patient with squint will come with diplopia, because I told you both the eyes should be in a one single visual axis. Both the eyes should be parallel. Okay, the visual axis should be parallel. Otherwise, what will happen? That the images won't be formed properly, and it will lead to what? The diplopia. Okay, so diplopia is a clinical symptom. Okay, yeah. Now ptosis. Ptosis is what? It is your weakness of the levator palpebrae superioris. Okay, the levator palpebrae superioris, if it is weakened, it will lead to the drooping of the eyelid, and drooping of the eyelid is known as your ptosis. Okay. Now the individual, the individual clinical of the nerve, the third cranial nerve is very, very important. Why? Because it will lead to the following symptoms. It will lead to the ptosis, obviously. It will lead to the squint, and it will lead to the loss of accommodation. I already told you that it is a connection with the ciliary ganglion, and via the ciliary ganglion it communicates with the pupil, and the pupillary constriction, the light reflex of the pupil, the accommodatory reflex of the pupil, they all will be gone if the third nerve is paralyzed. Okay, and there will be the diplopia. Okay, so these are the clinical features of the third nerve palsy. Apart from that, there is one syndrome, that is your Weber's syndrome. Now I told you that third nerve is related to your pyramidal tract. Okay, so whenever there is a lesion in the midbrain, if the patient is having in contralateral hemiplegia and ipsilateral paralysis of the third nerve, that syndrome is known as the Weber's syndrome. Okay, that syndrome is known as the Weber syndrome. Okay. Now, another is the abducens nerve palsy, which I already explained to you. Whenever there is a raised intracranial tension because of the long distribution of the nerve and long pores and sharp bends over the superior border of the petrous temporal bone, this nerve is having lots of wear and tear. Okay, and that case there will be the paralysis of this. There will be the palsy of this nerve, and it will lead to the paralysis of which muscle? As it is sixth nerve, it is supplying lateral rectus. So lateral rectus will be paralyzed. So the medial rectus will lead to the medial squint. Okay, so this is about the first part and the contents of the orbit. Okay, so thank you, and another part will be dealt in the second part of the lecture. Okay, thank you so much.